So I really want to thank David and the whole group for inviting me to come here and speak. My name is Mina Butra. I'm one of the physicians at the University of Pennsylvania, and the talk I was asked to give is entitled Communicating with Your Patients About the Risks of Therapies. But I also think it's important that we consider how we look at the risks of therapy in IBD. So I want to begin by talking about the risks of therapy with a focus on the immunosuppressants. And then, of course, you can't discuss risks of therapy without also considering the potential benefits of these therapies. And then I want to tackle two related topics. First of all, how do we put this together for ourselves, and how do we have this conversation with our patients? But before I begin, I think it's important to consider why we even need to have a talk like this at all. And it's because breaking with tradition is hard, but that's exactly what's occurred in the field of IBD over the past decade. Traditionally, we had step up. Now we have top down mixed with a little early aggressive, and more often than not, we're asking our patients to start not one, but two immunosuppressant medications at the time they're diagnosed before they've even had a chance to try any therapy. Now, there's plenty of evidence why these evolving practices are good, but breaking with tradition is hard, and it should require justification for change. So let's begin by looking at the risks of immunosuppressant therapy, and I'm going to focus on four classes of risks: the serious or opportunistic infections, lymphoma, hepatosplenic T-cell lymphoma, and progressive multifocal leukoencephalopathy, or PML, because these are the risks that worry us and, quite frankly, scare our patients. And I do want to insert a small disclaimer here. There is enough evidence on these risks to warrant a separate talk for each one. I'm only going to present a small portion of the evidence, and I will walk you through my estimates and my calculations, but the primary goal of this talk is to produce estimates for comparison purposes. And also, my husband makes me insert this disclaimer that I may or may not have failed my first grade math test, so take all my calculations at your own risk. So let's start with the serious or opportunistic infections. And if you PubMed infection risk, immunosuppressant medications, and inflammatory bowel disease, you will be sitting there for a very, very long time. The lists of studies I've put on here are not the most recent or the most widely cited, but quite frankly, they illustrate the wide range of published risk on published risks of infections with immunosuppressants, anywhere from 0 to 10% per year to a 14 times increased odds. Now, a fundamental question we should be asking ourselves is, what is the rate of serious infections in the general population? And this is actually a very difficult question to answer. The study by Grijalva in the JAMA article quotes a rate of pneumococcal pneumonia in the United States to be about 78 per 100,000 person years. If we accept that pneumococcal pneumonia is a serious infection, and we take a middle estimate of the ranges presented on the slide, notice the hand waving here, of maybe 3 times increased risk with monoimmunosuppression, 5 times increased risk with combination immunosuppression, and we do a lot of rounding up, we end up with approximately 3% or 5% per year risk with mono or combination immunosuppressant therapy. Now, arguably, these numbers are a little high, but let's use them for comparison purposes for this talk. So now moving on to lymphoma. When we worry about lymphoma risks in IBD, we're really worried about the thiopurines, the anti-TNFs, and combination use of these drugs. With regards to the thiopurines, I think the most widely cited risk comes from Candile's sentinel meta-analysis that showed a 4 times increased risk of lymphoma development with exposure to thiopurines compared to the general population. Likewise, Corey Siegel's meta-analysis showed about a 3 times increased risk with anti-TNF exposure compared to the general population, and more recently we have a couple of studies that have now looked at combination use and have shown anywhere from a 6 to 10 times increased risk of developing lymphoma on combination exposure compared to the general population. So for purposes of today, let's use a 4 times increased risk with monotherapy and 8 times increased use with combination immunosuppressant therapy. Now let's move on to hepatosplenic T-cell lymphoma. There are a number of case reports and case series describing hepatosplenic T-cell lymphoma, but I think perhaps one of the most intriguing articles is a relatively recently published population-based study that was done by Lisa Harrington using the Kaiser Northern California database. And in that database, they had a baseline population risk of 0.3 per million person years of developing hepatosplenic T-cell lymphoma. In their population, they had one young male Crohn's patient who had exposure to multiple immunosuppressant medications who developed hepatosplenic T-cell lymphoma. If you do the math, this translates into 160 times increased risk of developing hepatosplenic T-cell lymphoma with immunosuppression in IBD. Now, arguably, these are very small and therefore highly unstable numbers, but it is the first population-based study we have looking at this. Now, finally, I want to talk about PML. Now, PML is very interesting because it is the quintessential opportunistic infection. Quite frankly, it does not occur in the non-immunosuppressed general population. So there's no baseline risk in the general population. But what we do have are ranges of risks in our IBD patients who are exposed to natalizumab based on their JC antibody seropositivity, as well as the presence or absence of other immunosuppression. And these show, although very limited data, as I think Scott had pointed out, that about 1 in every 7,000 patients who is JC antibody negative can develop PML with natalizumab exposure. So let's use the 1 in every 7,000 and say that it's infinitely increased compared to the general non-immunosuppressed population. Now, I want to stop for a moment and share with you one of my favorite quotes. And this was written by a gentleman named Dr. Erwin Netter many decades ago in a manuscript that was entitled How to Write a Scientific Paper. And it reads, 33 1/3 of the mice used in the experiment were cured by the test drug. 33 1/3 of the test population were unaffected by the drug and remained in a moribund condition. And the third mouse got away. Obviously, Dr. Netter was illustrating how not to write up scientific results, but I love this quote because it so clearly illustrates how easy it is to make small numbers look very alarming, and therefore how important it is to know what the absolute risks are. Going back to the estimates we just came up with, we have numbers that are all over the place. We have percentages, we have relative risks, and we have infinitely increased risks. So let's try and convert these into some kind of absolute comparable form. First of all, it's easy to take our serious and opportunistic infection percentages and turn them into count data, such as 30 or 50 per 1,000 annual risk with mono or combination immunosuppressant therapy. Moving on to lymphoma, we can use the SEER database that tells us that the age-adjusted annual incidence rate of non-Hodgkin's lymphoma in the general population is 20 per 100,000. So if we take 4 or 8 times this, keep the same denominator of 1,000, we end up with 0.8 or 1.6 per 1,000 annual incidence of developing lymphoma with mono or combination immunosuppressant exposure. We can extend this analysis to hepatosplenic T-cell lymphoma, with the knowledge that T-cell lymphomas are 15% of all non-Hodgkin's lymphomas, and hepatosplenic T-cell lymphomas are 0.07% of all T-cell lymphomas. So taking 160 times this estimate, keeping the same denominator of 1,000, we end up with 0.0034 per 1,000 annual incidence of hepatosplenic T-cell lymphoma. Finally, when we look at PML, this is a little trickier. Again, we don't have a baseline risk, but let's just convert our 1 out of every 7,000 to keep the same denominator, making it 0.14 per 1,000, understanding this is not necessarily an annual risk. So now we've got everything into a comparable absolute form. So let's move on to the benefits of immunosuppressant therapy, or as I like to think of it, the risks of not using these drugs when we should. Because we know these medications work, and they work well. And more to the point, we know that stopping effective therapy is bad. In a study that looked at a population of Crohn's patients who had achieved a stable remission on azathioprine and then discontinued their azathioprine, by 36 months, over 50% of those patients had had a relapse of their disease. The ACCENT-1 study showed us that regularly scheduled maintenance infliximab therapy was superior to episodic or discontinuation of infliximab in preventing intra-abdominal surgeries and Crohn's-related hospitalizations. And in our patients who achieve a remission on combination anti-TNF and thiopurine use, stopping the anti-TNF medication was associated with a nearly 50% relapse rate by 36 months. And consider this, in our patients in whom we stop effective therapy and they relapse in the disease, or in whom we never initiate appropriate therapy and they continue with active disease flares, what is the medication we use? Well, it's steroids. But steroids are bad for many, many reasons. But in addition to this enormous litany of potentially serious adverse events, corticosteroids are associated with the highest infection rates of any medications in IBD. And these include serious infections, opportunistic infections, and postoperative infections. And I want to draw your attention to the fact that these are not ranges of risks like we saw with the immunosuppressants. These are stably reproducible numbers from a variety of different population-based studies. Also, steroids are the only medication associated with an increased risk of death. And this has been shown in 2 different population-based studies that showed anywhere from a 2 to 2.5 times increased risk of dying with corticosteroid exposure in both UC or Crohn's disease. Now you might say, well, steroids are just a surrogate for active disease because they are our go-to medication if someone has a disease flare. Active disease has also been associated with an increased risk of death, up to a 2 times increased risk of dying in both UC and Crohn's. So the goals of therapy should really be a stable remission off corticosteroids. But I just told you that immunosuppressants are associated with potentially lethal adverse events. And now I'm telling you steroids are bad, and obviously not treating our patients is bad. So what do we tell our patients? That life is pain and they're just stuck with no good options? Well, obviously it's not what we say, and this is where how we put this together for ourselves can help influence how we have this conversation with our patients. What we really want is a way to put all of these risks into some kind of comparable form to see how they stack up. And to do this, what we want to know is how many patients do we need to treat to cause or prevent harm? Now remember that number needed to treat or number needed to harm is quite simply 1 over the absolute risk difference. That's the difference in those patients who are exposed, for example, to a medication versus those who are unexposed. So for example, looking at the number needed to treat to cause 1 serious additional infection per year with therapy, using the baseline rates of serious infections in the general population of pneumococcal pneumonia and our 3 or 5 times increased risks with immunosuppression, we end up with about 500 patients treated with monotherapy or steroids, or 270 with combination immunosuppressant therapy to cause 1 serious infection. Now notice that I've given the steroids the benefit of the doubt here. I just told you that they are associated with the highest infection rates. So more likely, it's going to take fewer patients treated with steroids to cause 1 serious additional infection. Moving on to the number needed to treat to cause 1 additional lymphoma per year with therapy, using the SEER database as the baseline population risk. Candile's meta-analysis gives us age-adjusted rates for thiopurine exposure, which is useful because we know that lymphoma is more common in the elderly. So in patients over the age of 65, it only takes about 350 patients to cause 1 additional lymphoma. But in our younger patients, it's well over 4,000 patients needed to treat to cause an additional lymphoma. With the anti-TNFs, it's over 2,000, and even with combination immunosuppressant therapy, it's over 700. Looking at the number needed to treat to cause 1 additional hepatosplenic T-cell lymphoma, using the Kaiser database for a baseline population, it would take about 21,000 patients needed to treat to cause 1 additional hepatosplenic T-cell lymphoma. And finally, looking at the number needed to treat to cause 1 additional case of PML, again, a little tricky. We don't have a baseline rate in the general population, but let's assume their rate is 0. It would only take about 7,000 patients needed to treat to cause 1 additional case of PML. Now I want to switch gears. Let's look at the number needed to cause 1 additional relapse of disease by stopping effective therapy. Using the azathioprine study, it would take 3 patients. If you use the AXIN-1 study, you can calculate the number needed to cause 1 additional hospitalization per year by not pursuing regular maintenance anti-TNF therapy, and that's 7. Likewise, the number needed to cause 1 additional abdominal surgery per year by not pursuing maintenance anti-TNF is 21. If we treated all of our patients with corticosteroids, the number needed to treat to cause 1 additional death is about 150. And finally, if we did not appropriately treat our patients and they continued with chronic severe active disease, the number needed not to treat to cause 1 additional death is about 21. When you look at the risks like that, you might ask yourself, well, then why is changing the way we practice so hard? And it's because of differences in the way we perceive risk. As epidemiologists, we view risk as a measured property of a group of people. But as physicians, or more importantly, as our patients, they view risk as a measured property of me. And that perception becomes a reality. We tend to reject statistical reasoning in favor of anecdotal reports like I heard somebody, or I know of someone, or I read about someone on the internet. And we're far more willing to accept risks that we feel comfortable with, such as using steroids or having a disease flare, in favor of risks that are less familiar, such as PML or lymphoma, that seem more scary. But I think that as physicians, it's really important for us to always remember what the evidence-based medicine tells us, even when treating an individual patient. And I love this quote from Sherlock Holmes. While the individual man is an insoluble puzzle, in the aggregate, he becomes a mathematical certainty. You can never foretell what any one man will do, but you can say with precision what the average number will be up to. Individuals vary, but percentages remain constant. More recently, Nate Silver echoed this when he was describing the difference between a probability and a certainty in his election blog. We dare to pose the more difficult question, the one that a gambler or an investor might naturally ask: what are the odds? We calculate Mr. Obama's odds as being 2 chances out of 3. Not only will Mitt Romney win some of the time, but he should win some of the time if we have estimated our odds correctly. If the set of candidates you have listed as 67% favorites in fact win 95% of the time or 100% of the time, you've done something wrong. When we go back to the calculations I just showed you, I'm not saying that the risks are zero with immunosuppressant. In fact, bad things should happen if we have done the research correctly. What I'm saying is it's important to put those risks into perspective of how relatively rare they are, especially compared to the risks of steroids or inappropriately continued untreated active disease. But this brings us to how do we have this conversation with our patients? Because obviously we cannot have a conversation about number needed to treat or harm in the office. So we need some tools to simplify the discussion and make it easier for them to understand. Unfortunately, in the United States, quite simply, we stink at math. Over 50% of Americans lack the basic skills to apply math to print material. More generally, people overall have problems with risk presentation, framing, the difference between proportions and probabilities, and they tend to suffer from something called denominator neglect. So let's focus on each one of these briefly. Risk presentation refers to how we discuss risk, and we really need to try and avoid using vague labels, such as very low or very common, because patients have inconsistent interpretations about what this actually means. We already touched on issues of framing. Relative risks can make small risks appear very large, so it's important to try and use absolute risks whenever possible and frame your arguments in a similar frame, either a gain of frame or loss of frame for everything. Likewise, avoid probabilities, proportions, or odds, because these require conditional math. And if your patients are bad at math, trust me, they're really bad at conditional math. So try and use frequency and count data and keep the denominators similar. Patients tend to focus on that top number and completely ignore the bottom number. So very large denominators, such as 10,000, is absolutely meaningless if the corresponding numerator is also very big. In the end, you're still going to have some patients who hear any amount of risk, even 1 in a million, and say, that will definitely happen for me. And for these patients, I think it's useful to try and use some kind of a visual aid. We do research at Penn where I use a visual aid like this, and it's a risk grid that has 1,000 gray dots. And I say this represents 1,000 patients who do or did not take a medication, and the color dots would indicate the patients who do or did not have a bad outcome. So using our previously calculated number needed to treat or harm, if we had 1,000 patients treated with immunosuppression, this is the number who would develop hepatosplenic T-cell lymphoma in 1 year, and this is the number who would develop PML. If they were treated with immunosuppression monotherapy, this is the number who would develop lymphoma in 1 year, and if they were treated with combination immunosuppression therapy, this is the number who would develop lymphoma in 1 year. If 1,000 patients were treated with corticosteroids, this is the number who would die in a year. And if 1,000 were treated inappropriately and continued with chronic active disease, this is the number who would die in 1 year. If 1,000 patients stopped effective immunosuppressant therapy, this is the number who would require surgery, would get hospitalized, and who would have a relapse of their disease. In the end, if your patient's still unconvinced about starting an immunosuppressant, I think it's reasonable to offer them a trial of the medication. If anything, the Sasami study has shown us that at least for the risks of lymphoma associated with the thiopurines, the risk is limited to the time that the patient's actually exposed to the medication. And if your patient benefits clinically, they may be more prone to continuing with that therapy. So in conclusion, there are documented risks with immunosuppressants, but the absolute risks are low. Now, I did not discuss higher risk populations, such as the elderly or young men, but even in these populations, the absolute risks of chronic untreated disease or corticosteroid exposure are high. However, when we have these discussions with our patients, we need to be aware of numeracy issues, avoid vague descriptions of risk, use absolute counts whenever possible, and consider incorporating some type of visual aid. Now, I'll leave you with one last thought. At the end of the day, bad things are going to happen. Our statistics tell us that even though they're relatively unlikely, they're still they're a statistical certainty. And even the best fortune teller cannot tell you when a bad thing is going to happen. I think it's particularly hard for us as providers of care, because the whole point of us treating our patients is to do no harm and to make them feel better. So I'd like to leave you with one last statistic. At the end of the day, as providers of care of IBD, we have a better success rate than the best athletes' completion percentage, batting average, or free throw percentage, and those are some pretty good statistics. So thank you.